what is expressed as protein versus the whole genome, if you just look at sort of the exome or what's expressed as protein, about 70% of all proteins we make are expressed in the brain. So
Dr. Aaron Nelson, how are you doing, my friend?
Can't complain. Doing well. How are you?
I'm doing fantastic. For everyone watching us live, thanks for hanging in there. Had some family delays, but we are here. We are live, and we are ready to rock and roll to talk about child neurology, a specialty near and dear to my heart, as my daughter has some stuff that she sees a pediatric neurologist for. So one of our favorite questions here at eShadowing is, what is bread and butter pediatric neurology, child neurology?
Yeah. So child neurology tends to be a little bit more outpatient than inpatient, though like a lot of areas you can radically subspecialize and do things like pediatric neurocritical care or be a pediatric neurology hospitalist. Most people will ultimately end up seeing patients in the outpatient setting. If you're doing general child neurology, having done sort of the core ACGME residency, then most people will end up seeing a combination of headaches, developmental delay, seizures, which is a lot of what I do, and then a whole smorgasbord of sort of very esoteric rare diseases, which you may only see a handful of times in your life, but you put them all together and it's a lot of rare diseases.
Yeah, very interesting. So you mentioned ACGME training. What does the training path look like to be a child neurologist?
So it's changed a lot, and it's even changed in my sort of brief career and lifetime. So the pathway that most people will take nowadays will be to apply from medical school, whether it be allopathic or osteopathic medical school, and will apply to a categorical child neurology residency. So what a categorical child neurology residency is a 5-year combined complete residency experience where what you do is you do typically the first 2 years of general pediatrics training, followed by at least a year or so of adult neurology, and then at least 2 years of child neurology. So it's 5 years. When people are done with all of the 5 years, they can sit for their general pediatric boards. So they can board certify as a general pediatrician, do anything along that lines. But then they also are boarded as a neurologist with special qualification in child neurology. And so that's the path most people will take nowadays. Now, there are alternative pathways. There's something called a reserved position, which is only for the last 3 years of neurology. So for someone who's already done their pediatric training, or if you're in a unique situation where you know you're going to do pediatric training in one location but want to go somewhere else for your child neurology years, you can apply up to 2 years in advance for what's called an advanced position that are the final 3 years as well. But overwhelmingly, my advice to people and the pathway most people to take is to do a categorical child neurology residency over 5 years.
All right. Get there quicker, faster. That's good. Get out and start working. So when you talk about pediatric neurology, when you talk about rare diseases, what are, in kind of maybe lay terms or maybe a little more scientific clinical words, what types of patients do you see as a pediatric neurologist?
Sure. So we'll see a lot of rare diseases that have multi-organ involvement. So, you think about what is expressed as protein versus the whole genome. If you just look at sort of the exome or what's expressed as protein, about 70% of all proteins we make are expressed in the brain. So if you take a scattershot approach and say any sort of genetic mutation that's going to significantly affect a protein or cellular processing, there's an overwhelmingly high chance that it's going to affect the brain. So we see diseases that affect the heart in the brain, the lungs in the brain, the kidneys in the brain. It can be more severe ectodermal disorders. And so we work really closely with a lot of different pediatric subspecialists. And we work really closely these days with genetics and even neurogenetics, because a lot of the time, what used to be unknown diagnoses or unknown causes, more and more, if we do full genetic sequencing, we can get a common explanation for a panoply of different problems.
Wow. So how much does medical geneticists play in the role of a pediatric neurology?
Yeah, so it can be a lot. So where I work sort of at NYU Langone Health or Bellevue Hospital, we have dedicated geneticists. And so typically what we'll do is, depending on the concern, we'll usually identify what we think the potential genetic syndrome or syndromes could be. And then more and more people are moving towards whole exome sequencing or whole genome sequencing. But to do that, you need a dedicated genetic counselor. There's a lot of ethical risks and pitfalls for that. And so usually before we do that, we'll actually have them meet with a genetic counselor and a dedicated medical geneticist before they actually send the test, because you need to know what to expect and what the family could do with the information before you get it. If you're not in a situation where you have direct access to that, then a lot of child neurologists will send their own gene panels, and it can be everything from leukoencephalopathy gene panels for white matter disease, epilepsy panels for children with epilepsy, or migrational abnormalities, or autism. All of those sorts of things have these giant gene panels nowadays where you can do a direct approach and say, is it one of these causes?
Yeah. How much has the new kind of laws around open charts played into this kind of maybe confusion and stress and anxiety around patients and parents seeing charts before being able to talk to someone?
Quite difficult. So it's a whole thing. And as it's gone live, we use electronic medical systems, and our patients typically will have signed up that they can directly be checking their smartphone anytime, day or night, for test results. And overwhelmingly, we have to let it be released right away. There are sometimes unique situations where we can request a particularly sensitive bit of information be withheld, but most of the time it's gonna be released. And so it's really important that we both counsel them in advance for what some of the potential outcomes or findings are. And it really means that more and more we're on call, or someone from our group is on call all the time, because you can get a panicked call about something that may be of no consequence and you can reassure them, or a panicked call about something that's actually quite serious, and you really need to have a informed and lengthy discussion to try and talk about what's going on. And so it has made it a lot more work. I understand the ethical goal that patients are entitled to their information, but there's a lot of risks and potential downsides.
Yeah. Saeed asked a question. You had mentioned 70% of proteins, I think you either said expressed or at least are used in the brain, not made in the brain, correct?
Correct. And so, of course, if they're expressed in the brain, they may be made there or can be made and sort of transported there. Again, there's a whole host of different enzymatic diseases and processes. But a lot of proteins are ubiquitous, so to speak. So, for example, we're now embarking on a sort of new frontier of gene therapy, for example, for spinal muscular atrophy.
Zolgensma. That was my little more of a risque question about Zolgensma, which is the world's most expensive drug at $2.1 million, I believe it is.
Absolutely. And you compare that to the relative cost of some of the oligosense antinucleotide treatments that you'll use for SMA as well, which are not one-time treatments, but may be hundreds of thousands of dollars accruing year over year with these more invasive things like intrathecal injections and stuff like that, though I think things are hopefully moving more and more to reservoirs and stuff like that. But no, it's highly controversial because, of course, a large amount of money has gone into developing these things, and they're potentially curative. Though, back to what I was going to say sort of about the genes and the proteins and where they're expressed is we're going to enter a whole secondary phase of really uncharted territory as we selectively potentially fix the problem in the brain, but not always other organs. So there's actually the potential for children to grow into adults who have additional issues that we've never encountered before because children were not actually surviving. So there's a lot that still may come up over the next decades. This isn't a quick solution.
No, definitely not. And something as a parent of one of those kiddos, we're dealing with day in and day out. So definitely is important work. Why don't we jump in? I know you have some case presentation stuff that I know the students love. So why don't we jump into that?
Sure. So I was going to start off with an interesting real-life case that we saw on our inpatient child neurology consult service. And so I'm going to bring it up and start from there. And so let me know if you can't see it. But so much of the time, there's a few different misconceptions about neurology or child neurology. And of course, one of them that I think has fallen by the wayside is the notion that we can't treat things, because really, even genetic or neurodegenerative diseases these days we can treat along with seizures and headaches and a whole host of other problems, pediatric neuro-oncology. But there's also this notion that you can just sort of skip and be like, get the MRI and sort of get your answer. And so I wanted to go through a very interesting case where that really wasn't an option. And so what I'm going to try and do with this case is sort of talk about some of the difficulties that you can see when you're assessing neurologic changes in the setting of a complex genetic syndrome. For our discussion, syndromes that can affect multiple organs. Discuss a systematic approach to acute stroke or neurocritical care. And do it all without using any magnets or MRI imaging for reasons that will become clear as I go through the case. So a 9-year-old girl had migraines, a cochlear implant. So she presented to Grand Central Station with nausea, vomiting, diarrhea for several days, but then suddenly was unable to ambulate. And so that was what prompted her to come into the emergency department. And so her main complaint at that time was unsteadiness, inability to walk. But they really focused on her GI symptoms, and she was discharged. And so in an outpatient neurology follow-up, she was then assessed and immediately referred to our ED because of concerns for disequilibrium and ataxia. And so she has both Klippel-Feil and Pendred syndromes, which I'll talk a little bit more about, is therefore status post-mastoidectomy with cochlear implants, which precludes the ability to get MRI imaging. She's minimally verbal vocally at baseline and predominantly relies on sign language to communicate. On her initial review, she had no fever, chills, headache, or neck pain. Her labs were notable for an elevated inflammatory markers with an ESR 30, CRP of 14, platelets of 387, and a white blood count of 14. The initial exam description was quote-unquote non-focal from referring service. An LP was attempted but unsuccessful because of these initial symptoms. The reason the LP was unsuccessful will become clear once you take into account her genetic syndrome. And so she was actually seen in the emergency department and was markedly obtunded and was really not remotely at her baseline and was encephalopathic and not able to communicate in any meaningful fashion, even using sign language. And so she got a stat head CT. And what you can see is the significant artifact from her cochlear device there. But then what you also see, besides the lateral ventricles here, the cortical, you can see the gray matter, the white matter, is that you start to see these areas of hypodensity.
Yep.
And then over time, they become more severe, and there's more swelling and edema that you can see here with those hypodensities. And so at that point, you have a child who clearly has these inflammatory markers. You don't know, based off of this imaging, is this vascular, is this an abscess and a CNS infection? There's still a pretty significant differential, but then you look at the distribution, and it's posterior circulation. And so that's your first sign that you're dealing with something that might be more vascular. Though again, could be inflammatory, could be aneurysmal or mycotic aneurysms related to an infection, or could be due to something else. So as I mentioned, she has Pendred syndrome. So that's a syndrome where you have profound hearing loss due to inner ear abnormalities, disequilibrium due to vestibular dysfunction, thyroid problems that can develop later in childhood and adolescence, and is caused by a specific mutation in the SLC26A4 gene. But because of the cochlear implant, she cannot undergo an MRI. She also couldn't initially get a successful lumbar puncture for reasons that will become clear when you take into account her other syndrome. And so ultimately they had to do it under fluoroscopy. And that's because she also had Klippel-Feil syndrome, which is a genetic bone disorder with fusion of multiple cervical vertebrae, where there's a known risk of arterial dissection and stroke.
Wow.
They can often have multiple other bony abnormalities and can be caused by a host of different gene mutations. So this is a child with multiple different genetic abnormalities with multiple different genes implicated, presumably related to a larger area of either homozygosity or genetic defect. And so you can't do MRI imaging, you can't do an MRA. So then you're going to go directly to what you can do with sort of CT angio imaging. And so what you see here is her circulation. And so obviously you've got a couple of different findings. Here, which you can see in what we call sort of more this coronal sort of orientation. You can see you're looking at the top of the head down there. This is the neck down here. You can see the circle of Willis here with the anterior cerebral arteries. You can see the MCAs going off to either side. And you can see the basilar and the vertebrals coming in to form that. And down here on the vertebral, you see this giant amorphous blob. And you can see it over here when you're looking at the sagittal section as well. So you can see the front of the head, the back of the head. You can see where the corpus callosum and the associated blood vessels are running along. So it's a nice view of the vasculature, including significant abnormalities, as well as this area here, which is actually where the cochlear implant is. And so this is all sort of secondary to that. Therefore, she had a direct angiography done, and there's a few different things that you can see here. So she has, as mentioned, these bony vertebral abnormalities. These are not what vertebra will typically look like. You've got these abnormal fusiform areas here, and you've got these narrowings. Because when you think about how blood vessels form in utero and throughout development, they form in conjunction with the bones, the surrounding structures. And so when you have very significant skeletal abnormalities, then you will have associated blood vessel abnormalities, and they'll be abnormally formed, they'll be tortuous, there'll be abnormal areas of narrowing or expansion that are significant risk factors both for stasis of flow, also for dissection and aneurysm because of abnormal stresses or structure being placed on the blood vessels. And so if you look here, again, this is sort of sagittal, you can see teeth, you can see the cochlear implant here, but there's a very significant narrowing associated with where it's passing through that blood vessel. And you can see that here, this small area where there's bone on that side and bone on that side. So very clearly, we had reasons for this to be a stroke. And so anytime you have a stroke in a child where it's there's not hemorrhage, so you know that you're not dealing with a primary dissection or intracranial dissection, then you're going to give them aspirin, pretty much standard of care immediately. And we continued to watch and wait and see. And so over time, we saw evolution of the strokes. Stroke is defined by the World Health Organization as rapid focal disturbances of cerebral function lasting at least 24 hours or leading to death. For children, occasionally you can diagnose stroke even if they return to normal and it's not a transient ischemic attack because they have clear persistent deficits on their imaging. When we think of stroke, you can think about classic ischemic stroke, which is arterial ischemic stroke, or cerebral sinovenous thrombosis, which is a venous stasis process that then impedes blood flow. Or you can have hemorrhagic stroke. And so she was old enough that she falls under the childhood umbrella as opposed to sort of perinatal stroke, which is dealt with differently. So we're dealing with a child with an acute arterial stroke. The American College of Chest Physicians, the American Heart Association, all have general guidelines specific for children for stroke. And there's a lot of overlap. And so most people will do somewhere in the realm of, if you do in the realm of 1 to 3 or 3 to 5 milligrams per kilogram of aspirin, then you're pretty much in the right ballpark. If you want to hit all of them, you can do exactly 3. And so over time, it was clear that she was throwing off additional strokes. And so this was something that had to be dealt with. And so over time, you see evolution of these larger posterior circulation cerebellar strokes. And so even with aspirin, sorry, go ahead.
I was just saying, wow, that's large.
Yeah, and you really worry about that. When you have a posterior circulation stroke that size, you're dealing with the posterior fossa. And so even if the cerebellum is really resilient and can bounce back, you worry about swelling. Because if you have significant swelling in the posterior fossa, you can easily compress the brainstem. You can easily be set up for herniation. And so this is a very, very risky situation to be in. To the point where sometimes if you have a very large area, you'll think about something like suboccipital decompression, where you talk with pediatric neurosurgeons, you preemptively have them essentially disconnect the bottom part of skull so that there is room for the swelling without more severe injury or loss of blood flow. So given this, more angiography was done, and so they noted this very significant aneurysmal abnormality that you can see here. You've got this narrowing here at the Boney area, and really almost no flow. And what they saw is that they were actually having almost a retrograde flow. So they went over to the other side. And so what they saw here is that there was actually very extensive flow, and it was backflowing to the affected side where there was narrowing. So she really wasn't dependent on this vertebral artery for blood supply. It was already narrowed to the point where its only main function was to potentially be throwing off clots, which actually
I'm here to help.
Exactly, which it's actually doing here. So this absence of flow here is a tip of the basilar thrombus, so for anyone who has encountered that is exceedingly dangerous. That is something that you do not want to leave there, because if it actually cuts off the blood supply there, it can be very quickly potentially fatal. Yeah. And so that had to go in, was actually removed. So they did a thrombectomy. She presented at one point subsequent to that with additional changes that were concerning for seizure. She'd never had seizures before. It's not normally associated with her genetic syndromes. But the question was she seizing because of her old strokes, or was she actively seizing because of a new stroke? And so we already knew we would see strokes if we looked at her CT exams. We couldn't do an MRI, which is what you would normally do to look for new diffusion-weighted changes as indicative of cytotoxic edema. And so what you're seeing here is actually a CT perfusion scan to actually look in real time at sort of blood flow to see whether or not there was any evidence of a penumbra or an area of the blood supply that was poor and potentially could imply a stroke. Unfortunately, there was not one. And then she recovered, and more time went by. Eventually, that giant aneurysm had to be dealt with because it was at risk of both rupture and continuing to potentially act as a nidus for clot formation that could then propagate and block off the main vessel. So it was coiled. So you can see that little coil there. On the side, it becomes much more obvious. So all of this is just basically coil, where the whole point of this is, well, we've got her on aspirin. We want that actually to clot off. So you put the coil in there, it induces stasis, and it will clot off, and then it's not a risk for further aneurysmal formation or progression over time and rupture or further clot.
Wow.
So she had no more strokes. So she basically had one of her vertebral arteries taken down and basically obliterated so that it couldn't continue to throw off additional clots because it was not functional for her blood supply. She had the aneurysm coiled. She had that tip of the basilar artery thrombus resected. Her seizures eventually stopped. She had no more seizures. She had follow-up EEGs that were normal. After 2 years seizure-free, which is our usual standard metric with normal EEGs, we weaned her off of the Keppra, and she stayed seizure-free. Early on, she was very, very ataxic. Because remember, this was a girl who was not able to communicate verbally. Her entire family actually spoke Spanish, but they communicated with her with sign language. So typically when we were communicating with her at the bedside, we were doing a combination of Spanish language interpreter along with sign language interpreter to try and figure out what her mental status was, which was very difficult. Because you can imagine someone who is profoundly ataxic trying to communicate in sign language, and that didn't go very well. But fortunately, as I mentioned, the cerebellum is incredibly resilient, and so as she improved, the ataxia resolved, and then her mental status improved to her baseline. And so we've been following her for years since. She has no cognitive deficits, no impairments to her independence for her age. She's age appropriate for that. She continues to communicate via sign language because she is deaf. But the last visit that I had with her, she was spending time playing with her newborn baby brother. Basically considered it a hassle that she still had to talk to us, and was your usual, almost bordering on adolescent at this point. And so the big thing you always want to think about, and this is a good illustration of this, is what are the goals of stroke prevention? And usually, if you're in the very hyperacute time window, your goal is to salvage the brain and hope that it's not irrevocable injury. But most of the time, that ship has sailed. For pediatric stroke, it's very common that usually it takes children about 6 hours for the stroke to be recognized by family members, but then another 18 hours or so before it's recognized in the hospital setting. So usually you're already 24 hours out, which is unfortunate and something to be worked on and improved. But therefore, what you're trying to do is prevent additional strokes from whatever the underlying cause is. And so for patients who have potentially magnetic hardware, you have to be prepared to use other imaging modalities or localize based on your exam. Like, these are things that are still incredibly important. And you want to really remember what a patient's baseline is when assessing for neurologic change. Because if someone didn't know that she was deaf at baseline, then that could lead to a lot of faulty assumptions about what her mental status in fact was. And then, as I talked about when we talked about her Boney abnormalities, you need to remember they have a lot of secondary effects on vascular formation and can be a big stroke risk factor. And so for her, as in most acute strokes, the very first thing you're always trying to figure out is it a hemorrhagic stroke? If not, you give aspirin. If they're having seizures, you treat them, but otherwise you don't preemptively give seizure prophylaxis. So she wasn't given seizure prophylaxis, but once she started seizing, her seizures were treated. And then when you're dealing with an acute stroke, you need to really take a targeted history and do a very rapid physical exam, but you can't neglect the consideration of genetic diagnoses or a family history that can point you to that. Because in this situation, it was really a direct thing pointing at what the diagnosis was. She already came to us with these known genetic diagnoses and names. And so by recognizing what they were and what their relevant impacts could be on her risk for stroke, that let us very quickly narrow down what was likely going on, much more rapidly than otherwise.
Wow.
So that was my sort of acute inpatient case, which I think is a nice example. And I obviously picked because it's got lots of great pictures and you can see different imaging modalities and stuff. But I'd be happy to answer questions about that or other things.
So it's funny. Adrian said the human brain is so resilient, and then Hasanat said, especially young brains. Why are young brains so plastic?
That is a good question that honestly people don't yet know. But there's a few different things to think of. When children are very young, the brain is still developing. And so you still have a lot of the developmental windows that you can hit. So for example, when we do epilepsy surgeries, there are rare epilepsies like Rasmussen's encephalitis, where you may have injury to one hemisphere over time. And those children will do much better if you actually intervene earlier and do a functional hemispherectomy and essentially remove the affected hemisphere before they hit all of their critical windows for language, because it's much easier to organize on the other side. So one of the big things that helps children early on is the fact that if you have unilateral injury, they're very good at remapping to the contralateral side, which is not true for older children and adults. It's clear there's genetic factors that also affect two people of the same age. One person could have the same stroke as another person and then recover wildly differently and wildly better, and that's for reasons we still don't understand. There's active research going on to try and recognize that and potentially replicate that from a chemical or a therapeutic perspective. But it's very clear that very early on injuries, children can do much better. And so we often will incidentally find very significant neurologic injuries on imaging when we're doing imaging for other reasons. Because as I said, one of the big common things we see is headache. And so it's always an interesting discussion when you get an MRI for someone for a headache and they have a significant other lesion or old injury, and you have to explain that it's really not causing their headache. It's got no role or impact on that, and they've developed normally. And if they hadn't gotten the MRI done for the other reason, they would have never known about it in their whole life.
Yeah, an incidentaloma, as they're known. Very cool. Let's bring on some students who have some questions. If you want to come on, let me... I'm going to clear out the stack, and then if you want to come ask a question, go ahead and raise your hand. So Faral asks, why does the cochlear implant affect the ability to get an MRI?
Good question. So it's about what the MRI does. So it's a situation where it induces current or heat. So if you have, an MRI uses very, very, very giant magnets, right? So magnetic resonance imaging. And so it's generating a very, very, very powerful electrical field. And anytime you do that, if you have a linear element or something that electrons can flow along, you can induce a current. And when you induce a current, there's a couple of different things that can happen. You can have electrocution in a high-level sense. More often what you get is you get heating of the elements and you get burns. And so when you have things that have wires like that, then you just can't go in the MRI, period. That's as opposed to, there's other things, for example, some patients will have certain types of shunts that are set or dialed magnetically. They can still get MRIs, but you have to know that when they undergo the MRI scanner, that the shunt has to be reset afterwards or won't function properly. And again, you can pick metals that are actually okay to go in the MRI. Even when we do EEG or electroencephalogram, which is designed to measure sort of voltage and electrical difference, there are MRI-compatible EEG leads. So if you need someone to be able to go in and out of a scanner, you can preemptively pick something that's safe. But that's why the cochlear implants, they've got wires. They're deliberately communicating to, try and conduct and convert what's happening in the acoustic world into signals that the deeper part of the inner ear can understand, bypassing where the hearing deficit is. And unfortunately, those involve conducting elements.
Bad stuff. Big magnets. Bad stuff. All right.
You always got to know. People don't always know what metal they have. And so if they don't know, they can test. They can actually pulse and ping the patient, basically, to make sure that there's not something that causes metal before they actually do the whole scan.
Wow, that's interesting. All right. Daniel, hello.
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 Okay, so I just had one question. So you were talking about rare diseases and you sometimes see them. Have you seen anybody, I've heard of this like syndrome where children develop like obsessive compulsive disorder like symptoms after having strep throat?
So yes, so there's the whole spectrum of sort of pandas. or pandas-like syndromes, and then there's the question of sort of the OCD or tic component of more like a Sydenham's chorea. So, right, the original description of this sort of poststreptococcal syndrome, which originally came back in the day when there was whole lots of more rheumatic disease, was that the very early ones were with Sydenham's, where you'd have the streptococcal impact, and then you'd have the antibodies, and it causes an inflammatory response, and they'd actually develop all of these abnormal movements. And actually associated with it, but much less bothersome, were some of these anxiety or OCD-like symptoms. And now there's, some people call it PANS, some people call it PANDAS, but this notion that there is a sort of post-inflammatory process, the body revs up antibodies against the streptococcal infection, and then that causes inflammation in the brain and some of those sort of neurocognitive side effects. It's a real phenomenon. There is some good data that shows that in subsets of the patients, if they take like organotypic brain slices, that they can see that there is antibody binding. That said, I think it is overdiagnosed. Tics and obsessive compulsive disorder are very common and often have a genetic element. And it's known that when you are stressed, and stressors include medical sickness, emotional stressors, all those sorts of things, it will often tend to worsen the anxiety, OCD, and even the tic component. And so, so it's a very complicated problem. For some individuals, there's evidence that if you really have good time correlates between infection and flare-ups, that you might try treating with immunomodulatory treatment. Most people will try and eradicate any endemic strep colonization to decrease that. But I think oftentimes it ends up also being a scapegoat. So I always am a little bit worrisome if someone has leapt to that as the first diagnosis and explanation without exploring other alternatives.
Okay, thank you.
Good question, Daniel. All right, Amy, hello.
Hi. So my question is, for children who have seizures in their childhood, first, like, what causes those previously, like, unstimulated or unknown cause for seizures? And then two, how do you distinguish those children who have seizures that they're going to have them in childhood and then never have that affect them again in adulthood versus those who need to be worried about it long-term throughout their lifespan?
It's a really good question. And it's a question we get a lot from parents and families too. Because seizures are incredibly scary, particularly if it's your child and you're watching it go through and you really want to know sort of what to expect. There's a few sort of general truisms for children who are, if a child is seizing right at birth, it's most often hypoxia or stroke. If they're very premature, it's more likely intraventricular hemorrhage. But once you get out of the perinatal period, very early childhood disorders are overwhelmingly genetic. And so we'll often do very, very rapid ramp up of genetic testing. We'll usually get an MRI and try and get a look, make sure there's not some other obvious explanation. And then what their prognosis is often at least very significantly dependent on what the specific genetic cause is. But even then, it's not that simple. There's a lot of ongoing work trying to correlate between genotype and phenotype. And what we've learned for a lot of neurologic diseases, including epilepsy, is that there's a lot of overlap. So you can have different genetic mutations that look identical in the patient, and then you can have two patients who have the same genetic mutation with very different outcomes. And the classic example of this in the epilepsy world are SCN1A mutations, which are a sodium channelopathy. And that can be everything ranging from children who never have seizures or just have an abnormal EEG to children who just have febrile seizures, all the way to benign but easily controllable seizures to Dravet syndrome. Which is a very medically refractory developmental and encephalopathic epilepsy. And so the problem is the genetic answer doesn't tell us what to expect. For children who are older, if they have normal imaging and normal development, it's very often microscopic abnormality in cortical development that they can grow out of. And there's certain genetic syndromes that they're going to grow out of, and certain genetic syndromes that they're unlikely to. And then a lot of things that fall into the gray area, which is why we really try and manage the individual patient based on how they're doing, what their EEG looks like, how things have progressed over time.
Okay, thank you.
Very good question. Thank you, Amy. So a good question here for someone from Elizabeth. How do you know to utilize aspirin, or why is it safe to utilize aspirin when there's a risk of Ray's syndrome?
So it's a good question. So Ray's, you're worrying about a sort of neurometabolic syndrome affecting the liver. There used to be always this concern of you don't give any children aspirin, right, because of this. And so, and it's a classic question. And it's not that it's no risk. It's typically, those are usually risks in children who may have a heretofore undiagnosed sort of neurometabolic disorder and disease, and it's quite rare. And then also the fact that it's unusual to have an issue with just sort of a single dose. And then it's weighing risk versus benefit, in all honesty. And it's the known clear benefit of having the antiplatelet effect on board to both, if there are clots, help the body start breaking them down. It's not a clot busting agent. It's not like TPA, but it'll allow that. It'll shift things, thrombosis and thrombotic buildup, to allow it to be broken down. And the risk is just so much higher if you don't treat. And the alternatives are anticoagulation, like heparin or enoxaparin and those sorts of things, which we will use in certain situations. But there are some situations where those are very high risk as well, things like intracranial dissections, where we'll usually try and avoid the more extreme anticoagulation because the risk of hemorrhaging in the enclosed skull vault is so high. So it's not that it's not a consideration, and it's very good that you know that, because that means that you'll get at least a couple of questions right when you take your shelves and when you take your boards and stuff like that. So it will come up, and you don't want to forget that. But it's just a situation where it's exceedingly rare, and the benefit outweighs the risk.
Definitely. Always that calculation. Lucas.
Good evening. What is the neurologist's relationship with the neurosurgeons? It seems like these cases might involve a number of surgical interventions, and I was wondering, where's the management, where's the handoff of the patient between the two?
Yeah, it's a good question. There's a lot of overlap, and we work really closely with the pediatric neurosurgeons where I am, and so I know them all quite well. We'll often work up patients from start to finish if we're working them up for epilepsy surgery, for example. But in the acute inpatient setting, it often boils down to historical relevance or what the treatment is, because of course about the only procedure that I would do as a neurologist is either a lumbar puncture or an EMG nerve conduction study, which is honestly not going to help anyone in an emergency. And so the neurosurgeons, if you're dealing with a situation where there's cerebral edema, you want them involved, because they are typically going to be the ones who would either go in and do something decompressive, like a craniectomy, a burr hole, put in a bolt to directly measure that, do any other disconnect for that. They therefore, because they do those things, organically, I think, over the history of their field, therefore also took management of hypertonics, like hypertonic saline or mannitol or those sorts of things, which in theory, neurocritical care people will also manage, and child neurology can manage. But since the neurosurgeons are sort of doing one end of that, it sort of makes more sense that they're managing all of those aspects together. But we will often follow patients with them from start to finish in the hospital, because we do a lot of complementary things. While some pediatric neurosurgeons are incredibly good at the physical exam, they often appreciate our involvement sort of following their patients as well, just to be sort of looking for any other subtle issues or signs or symptoms that may be going on outside of what they've been directly addressing from a neurosurgical perspective. So we co-manage a lot of patients.
Awesome. Thank you.
Thanks, Lucas. All right, Terrence. Hello.
Hello. I cannot see anything, but hopefully, can you guys hear?
We can hear you.
We can hear you, yes.
All right, that's great. All right, so personally, I'm interested in neurology too, and actually, when I was a child, I actually went through something dealing with the nervous system. So I went through, I actually contracted Guillain-Barré when I was younger, and it eventually turned into CIDP. And so what the doctors told me, I could have gotten it from my vaccine. So would it be safe for a person that got an autoimmune disease from a vaccine to take, let's say, the COVID vaccine?
So that is a very loaded question that I will still give you an answer to. So when you're dealing with someone who has a specific neuroinflammatory disease or a high predisposition to it, it's sort of weighing the risk versus benefit. So, for example, someone who is in the midst of a pediatric MS flare would probably not be the time that we would want to do that and vaccinate them. Though ultimately they're going to end up immunocompromised, we would want them vaccinated. Someone who is prone to seizures, for example, if when they get vaccinated, they'll have a 24 to 48 plus hour window where they might be at a higher risk for breakthrough seizures. Now, but for someone who has a single episode, they'd really have to make a personal decision about the risk versus benefit, because it's a situation where my best understanding, and this is not my area of expertise, is that the risk of a demyelinating polyneuropathy or a Guillain-Barré style syndrome is higher with actual COVID infection than it is with the vaccine. That said, it can be triggered by the vaccine. It genuinely, those sorts of things can be. So the short answer is I don't know. I think you'd have to sort of weigh the relative risks versus benefits. You'd have to think about sort of your overall health otherwise and what the risk would be posed to you by COVID, for example. So I don't have a good answer for you personally, but it's not a non-issue. It absolutely can potentially trigger a Guillain-Barré style syndrome, and that's true of a number of vaccines, but including the COVID ones.
All right, thank you so much.
Thanks, Terrence. Sawith.
Hello, can you hear me?
Yeah.
Okay, so my question for you is, how did COVID affect your patient population? Like, for example, what kind of neurological complications do you see with kids who contracted COVID in terms of like long haulers or like something like that?
So I can speak to that without tipping too much. My hope is that we will have a publication out about that in the not too distant future.
Isn't it so funny how the medical world like hides everything so that we can publish and present at conferences?
Well, I'm not the PI, so it's not my information to give. But I can talk to our own personal experiences because I was in New York and through all of the early sort of peak of stuff in the Northeast. Definitely there is real neurocovid. It can cause encephalopathy and brain fog. We saw a number of patients where it was likely a factor in their seizure or seizure exacerbation. We had one case report that I think got accepted as a poster that was about a reactivation of infantile epileptic spasms for a patient who'd been in remission and for a prolonged period of time and seemed to have reactivation of their infantile spasms in the setting of COVID infection. And so there are a lot of direct effects. I mean, it's a situation where we know it directly infects and infiltrates the brain. That has been shown. And it's very clear that a lot of the persistent effects of long COVID involve those effects and potentially also inflammation, because there's some evidence that the longer term stuff is sort of a more chronic neuroinflammatory process, in addition to other organs and stuff when you start talking about MISC. So you see headaches is one of the big things, in all honesty, encephalopathy or fatigue. Obviously, anosmia was one of the big things everyone was focused on early on. And the thing to realize is the anosmia itself is a neurologic thing. That's your free nerve fibers from your nose to the cribriform plate. So it affects a whole host of neurologic symptoms. It's one of the reasons why I'm a big proponent of vaccination, because it's very clear that there are significant and potentially long-term complications of the direct infection.
Okay. Also, just a small follow-up question on what you said. As we discussed earlier, you said that like young brains have the potential to like hit critical periods and still like be able to get over certain things that happen like as a kid. So when you compare like a younger patient to like let's say an adult who's had COVID, are the neurological complications different? Would you think so?
They are different. It's so early that I don't know that I can say much of anything about longer term, because this is all so recent. The reality is that, yes, I mean, children, when they're particularly very young children, are still much less affected than adults or even older children, though, everyone's keeping their fingers crossed that there's not some new wave or new variant or something like that obliterates that. So the short answer is I don't know. There is good reason to think that both children are less severely affected, all things being equal when they're infected, and that, yes, as we already talked about, all things being equal, children tend to be more resilient in their brains at an early age. But I don't think we know enough to have a real sort of long sense of what things will look like even, 3 to 5 years from now.
Okay, thank you so much.
Good questions. All right. So, Dr. Nelson, as we wrap up here, for someone who may be interested in pediatric neurology, what are some kind of final words of wisdom for them to go out there and continue to learn some more?
Sure. So I would think about child neurology, but then think about the areas around it. If I hadn't done child neurology, I probably would have done child psychiatry or developmental and behavioral pediatrics as opposed to adult neurology. Other people are drawn to the field of neurology and then are trying to decide adult versus pediatric. So I think that's the first thing to think about is if you're sold on neurology, do you want to work more with adults or children, or both, because you can do both? Or are you really more interested in working with children who have neurologic or developmental issues, and then how do you want to work with them? Because it's different based on the individual field. If you are in an area or part of the country where there's just not as much child neurology, it's a niche field. There's areas that are very dense and rich in it, like the Northeast, Texas, and California, but then there's areas where there is not a lot of programs or exposure, then I really recommend trying to seek that out, whether that be a visiting elective or some other version of virtual shadowing if programs are still doing that, to get that exposure, because you won't know that you like something if you don't do it. And you're sort of stuck imagining it. So that's my biggest advice, is to seek out the exposure early on in medical school, because otherwise, I always talk to people who tell me how they did it, their fourth year, but they'd already decided what they were going to do, and that they might have switched what they were going to do if they'd known it was even a field or a career earlier. Yeah,
very interesting. Well, I appreciate you coming on and taking some time with us and the 240 students that stuck it out the whole way through. It was an amazing case and lots of great things for students to learn. So thank you again from all of us, and to everyone else, have a wonderful evening.
Thank you for having me. I really appreciate it.
Bye, guys.